Well, good afternoon. I'm Marilyn Benoit. I'm a child and adolescent and adult psychiatrist and a past president of the American Academy of Child and Adolescent Psychiatry. Um, right now, doing consulting to a therapeutic day school for kids with severe emotional disorders. And I also have a small private practice and continue much involvement with the American Academy of Child and Adolescent Psychiatry. I thank you for inviting me, and I look forward to an hour that is going to be quite dense. I will try to save about 20 minutes for discussion. And with that, let me get started. Okay, so we'll be focusing today on the pharmacological strategies in ADHD. However, because I never like to jump into a topic without saying how do you define the thing we're talking about, I'll be doing some of that and going through very quickly, okay? So what are the goals? To talk about what common medications are, treating uncomplicated ADHD, the complexity that we see in ADHD when there are comorbidities and how that leads us into using polypharmacy. And I can't overstress, let me tell you, because I work in the school system, the importance of school collaboration in calibrating medications and also the importance of family intervention behaviorally. This is just to indicate, yes, ADHD happens in the brain, okay? Very important. It's a neurodevelopmental disorder defined by impairing levels of inattention, disorganization, and/or hyperactivity, impulsivity. And it causes a lot of impairment in the executive functions, that's in the frontal lobe. Just quickly to talk about the fact that yes, your pediatricians, primary care early on, but these people grow up and that there is a whole lifespan implication for what happens with ADHD. So that in preschool, you primarily get the hyperactivity or inattention, elementary school, and I'm not going to go through all the fidgetiness, etc. But in adulthood, along with the inattention, restlessness, impulsivity, you get people who are just unable to do their job essentially, because it gets in the way of functioning in an office and with a team, etc. What are executive functions? Quickly, they are what we use to live our lives: organizing, prioritizing, planning, utilizing your working memory, accessing recall. And I'm not going to go through every single one of it, but part of this is managing frustration and modulating emotions. And as we know, those are two things that when kids get into trouble with that in school, they really have difficulty learning, getting along with others, etc. This is just another graphic to show executive functions, frontal part of the brain. Again, what are the primary core symptoms? You have distractibility, impulsivity, hyperactivity. I'm not going to go through all of this. These are the DSM-5 criteria by the American Psychiatric Association. You can find them quite easily, but I wanted to point out that there are some criteria that are used, and it's not just you see a child being hyperactive, oh my God, that kid has ADHD. No, that there are other things that need to be looked at in order to come up with the diagnosis. Again, here are more of the specificities that you see in the DSM-5. I just want to go through this a little bit because these are what I think when you fill out your checklist, the things that come to the attention of pediatricians. Difficulty awaiting their turn, blurting out answers prematurely. They cannot wait. Unable to stay seated. And I said, so I'm in a school where I look at this with kids. And I mean, some kids are literally climbing the walls. They cannot stop for a minute to pay attention to a question answer. Interrupting, intruding upon others, very intrusive in terms of personal space, not being able to define what seems appropriate socially. Fidgety, squirming. Very often you see tapping the hands on the laps, tapping the feet on the floor. I talked about the inappropriate running, climbing, talking excessively. You can't get them to stop. We call it diarrhea of the mouth, on the go, and just difficulty engaging in leisure activities quietly. Unless, and we can, seems like a sort of, it doesn't match. When kids are involved in something that they're very interested in, they can sit with it for hours. And one of the things that we see is that they can get involved in video games and sit with it, and the parents will say, well, that's not a hyperactive kid, but that's because they have that extremely hyper-focused attention on that one thing. But you can't learn in school if you only can focus on one thing. Novelty seeking, we've talked about that, and risk taking. Risk taking is very high because they don't seem to appreciate dangerousness. So that one kid said to me, he said, I'm really clumsy. I bump into everything. And they primarily inattentive, and then the combined time, you see both the inattentiveness and the hyperactivity. And I'll say here, it will come up again in our discussion. The fact is that boys are diagnosed much more than girls. And part of that reason is that boys by nature are just more active and they show more hyperactivity in the classroom and that therefore more recognized and identified. Girls tend to be more inattentive. We'll talk about that again. So the literature quotes anywhere from 3 to 10%. And I think it depends on your demographics. And it depends on how people are identifying. As I said here, prevalence rate differs in different countries because of cultural differences, diagnostic criteria. In general, the DSM reports that population surveys report anywhere from 5% of children. And because it seems that people's brains can actually adapt and accommodate to some improvement, you can find that with adulthood, there's some decrease. But you really need to be sure that you're looking at perhaps some different things in adulthood, but I'll leave that alone for now. We're talking about children. Repeat here, because girls are less likely to be hyperactive, they're not as identified as boys are. I have a chat, one of the things I want to do as we go along is to mention patients. I've been in this for 40 years, and so I've had a lot of patients, and I'm thinking of one young lady who was just called a space cadet. And I'm only thinking of one person, but this happens quite a bit. And they're called daydreamers. It turns out that in her family, she had brothers who were identified and diagnosed with ADHD and being treated, but she had not been identified. And when she came to me as a patient in her teenage years, and I took this history, I also sent her for psychological testing, and it revealed, yes, she has inattentive type ADHD, ADD, we'll call it. And she then went on to, I treated her with medication, and also because this part is really important, because you might have to seek accommodation. That is what I did for her. Long story short, I had to seek accommodations for her all through high school, college. She then took the, so what we want to do an evaluation, okay? So somebody is going to send a child to you, or a parent who has been, observant will bring your child to you with some complaints that I think my child is hyperactive. It's really important at the same time to assess for other things. And you can do this with a questionnaire or maybe just in terms of the evaluation, look out for anxiety and depression, Tourette syndrome, obsessive compulsive disorder. And I want to underscore, because all of us are seeing these children, post-traumatic stress disorder. I think it's highly undiagnosed, and so many kids who are dealing with a lot of trauma, neighborhood environment, are dealing with a lot of trauma, and I see that they can manifest behaviors that definitely look like ADHD. So I really want to underscore that, to begin to a child who might look as if they're daydreaming. Oh, excuse me. And if somebody might think that's inattentive ADHD, it might be, absence seizures. So that you want to at least have a broad, what we as medical providers do, we always talk about that, what are we looking at in terms of diagnosis? Okay, very important, as I mentioned, the comorbidities. What you will find is that oppositional defiant disorder is one of the most important, the most prevalent comorbidities. Depression, anxiety, learning disabilities, want to underscore that because when children are unable to learn, they often attributed to poor adherence. And I can't tell you how much that happens because, and what I find with the families that I deal with, so you start them on the medication and there might be some side effects. Common side effect being maybe difficulty sleeping and decrease in appetite. For some reason, parents have a hard time seeing their children not eating, okay? It really makes them anxious. And when they see that, and because I know today a lot of difficulty kind of reaching the doctor, reaching the prescriber, people tend not to call and say, this is what is happening. And instead, they stop the medication. And that is something that I have found way too often. So when you do start, please give a phone number that somebody can call, a triage nurse, whoever, that they can quickly give you feedback about medication. And the other thing is that we see that there were suboptimal doses of medication given. And I think that in some cases, primary care docs or healthcare providers are afraid to push the medicine a little higher. And in that case, I think that if you can just consult with somebody like myself in your community, that they can help you say, okay, it's all right to go a little higher. I want to tell you one story of a situation where I got referred a child who had been seen by a primary care person, and the parents came to me because they said, this medicine isn't working. He was on methylphenidate, and the doctor, I don't know why, gave him the medicine to take at bedtime. So what happened is, number one, he wasn't sleeping. It didn't work in the daytime at school, so the medicine wasn't working. And what that provider did was to keep increasing the medicine. By the time he came to me, and I have never seen this before and since, he was on 140 milligrams of methylphenidate at night. He had then developed an OCD picture where he was taking showers all the time. So here was a case where somebody just didn't understand how to manage the medication. And unfortunate, and thank God he got to me before anything bad happened. So we were able to stop that medication. Long story short, this young person has now grown up, he's married, he has a job, he's had a child recently. Changing the trajectory, that's what we need to do. Okay, so some of the variables in the MTA study that were found, parental affective illness, aggressivity, and the comorbidities I mentioned before. I want to mention parental affective illness because, the parents bring the kids, and as healthcare providers, I think it's okay that even though you are not a mental health person, to ask a parent how they're doing. I'll give you another example of a child who was brought to me. and he was in preschool. And, the parent brought the child, and in just taking the history, I realized this woman looked pretty depressed. So I turned to her and asked, "How are you doing?" It turned out she was very depressed. She was involved with a cocaine abusing partner, and the child was being neglected. So his behavior was really an attempt to try to engage his mom. I didn't see him. I treated her for depression. She got better. I treated her with medicine and psychotherapy. She got better. She left the partner. She got her GED, got a government job, and life went on with a better trajectory for both her and her son. So again, very important to pay attention to the parenting person. I'm not going to go through all of this. I'll leave it for you to read about ADHD research. The only thing I'm going to highlight here is that the environment does play a role. So one of the things I'm finding more recently is that people are not getting social histories, so that you're looking just at this one little individual youngster and their behavior, but not trying to understand the ecosystem within which the child lives that might be eliciting that behavior, and that it may not be ADHD, it could be, but that even if you treat the ADHD, the ecosystem needs to be paid attention to. Not that I expect you to do that, but that at least maybe a referral to someone who can assist with that. Okay, so the whole thing here is that the last bullet point here is early treatment in childhood can change the trajectory of a person's life, underscore, underscore, underscore. Because what I find in working with some parents who are very hesitant to initiate treatment is that I have to talk about what happens if we don't, what could happen if we don't, so that to get, and also to share with them some examples of people I have treated that if we hadn't started in childhood, that person would have had a completely different life. Okay, we know parenting a child with ADHD can be stressful, demanding, exhausting. That is a quote from a parent. So when is medication considered? After an evaluation has said, okay, we agree this child has a diagnosis of ADHD. Who does the evaluation? I list here psychiatrist, a specialist nurse practitioner, child psychiatrist, a really psychiatrically trained social worker, developmental pediatrician, and nowadays, I would encourage you, I know it cannot be done all the time because of the shortage of psychologists, but if you can add or refer for a psychological assessment, that is a plus. The reason it's a plus is because very often when you refer and add and seek out accommodations, they want to have that documentation, okay? What does the medication do? This is a critical thing we're talking about. Helps the individual to focus attention, decreases hyperactivity. And I tell you, by my being in the school where I treat the children, you can actually see it happen. I go into the classroom and you see the child who was climbing the walls, being able to sit and pay attention and not be distracted by other kids around him, decreasing impulsivity. So those are the core symptoms. And so therefore, because that individual is more attentive, they can listen, they can learn, follow directions. And it's really nice to see. It was so cute. I have two little kids there. I think it's first grade. And to see them, and actually both of them are being treated, to see them interact and to talk about being best friends and go hug each other, it's just really charming. Okay. Additionally, when you treat adults, they also show significant improvement, focus, and completing tasks. I want to give you a case of this family brought their son to see me. So he was, I think, about 10 at the time. Then it turned out that their daughter also had ADHD. So I'm treating both of them. Meanwhile, the father's mother died and he was cleaning out her house. Father was having a lot of trouble with work. I mean, he was procrastinating, not completing tasks, etc. When he found his old classroom class reports, there was all the evidence of ADHD all over his class reports. And this is a man in his 40s at the time. So I was able to treat him and get him on a better track. Okay, so how do we go ahead? So these medicines have been around for more than 50 years. And I say that to parents because I said, their safety is really well documented. So the two major ones are still dextroamphetamine and lots of derivatives. When you look up medications, you might find about 50 different ones named with brand names, but you look at the generic, it's a derivative or dextroamphetamine methylphenidate. The oral delivery method, which is absolutely wonderful, and it came from space technology. What it does, it's a capsule that's on the outside is the first morning dose. The child swallows it, that dose comes off. Then it remains in the stomach. And because of the technology, there are 3 different compartments within that capsule and with laser openings that respond to osmotic changes in the stomach. And over the course of the day, there's a delivery of these 3 doses. So essentially, you get 4 doses in that one capsule and nicely distributed over the course of the day. What the research shows is that absolutely giving divided doses seems to be the best in terms of effectiveness. So that oral delivery method is the only one that does that. In addition, of course, we have the slow release and extended release, the SR and the AR dosing systems that are also preferred because it's a little bit stigmatizing for a child, for somebody to go to the classroom and say, okay, Johnny, time to come for your medication, This way we avoid having that interruption and that, sort of focus on the child during the school day. And there's the one thing, the patch. I'm sure you've heard about the patch. I do not use it. What I have found with the patch is that the kids just rip it off because they find it annoying. But if you get success with it, more power to you. The nicest thing is when you get uncomplicated ADHD. And it's just, where you don't, everybody I'm sure is familiar with adverse child experiences, ACEs. And uncomplicated ADHD generally happens in a situation where you don't have a whole lot of ACEs in that child's family experience. So I said, this is a truly wonderful thing when it happens. There are no complex psychosocial issues, no learning disabilities, no other medical issues, and you simply have one thing to focus on. In a case like that, once you have started the medicine, and we'll talk about starting, and you have reached a stable dose, then you don't have to see that kid maybe about every 3 months, because the stabilization, you get some reports back from school, from the family, and this is the nicest one. Doesn't happen often, but it does. So other medicines that are used are clonidine and guanfacine. Both are FDA approved for the treatment of ADHD, okay? And they are quite effective for more of the highly impulsive type. They are extended release preparations, which you can give at bedtime. And one of the nice things about that is that so many kids with ADHD have sleeping problems, and this helps them with sleep. And so, you get your sleep history before you start. And it's also always nice that, I talk to the parents, oh my goodness, he's just sleeping all night long. Great. Then we have to think about the side effects. And before starting usage, and which you, of course, you have to talk to the parents about. So clonidine and guanfacine are highly sedating, and they kind of impair the child's ability to stay awake in the classroom. I inherited one child who was getting the ER at night, plus getting immediate release in the morning, and he was sleeping the entire morning until lunchtime. I mean, that's a, kid isn't learning. So we want to medicate to assist with functioning that helps the child learn and move on ahead developmentally. So you really have to calibrate this carefully. And I tell you, the worst thing is to try to cut a clonidine in half. It is the tiniest little pill, but sometimes you have to do that. May have to end up wasting some, but monitoring what happens during the classroom day is very important when you use these two. You've heard of the non-stimulant atomextin. It takes longer to work, so that, whereas with the methylphenidate and the dextroamphetamine and with clonidine and guanfacine, the result in terms of decreasing hyperactivity, improving attention, happens very quickly. With this, you've got to wait 4 to 6 weeks. Because of that, I have to tell you, it's not one of my favorites. And in terms of, I actually talked to my colleagues through a chat about this before preparing the presentation, and it's definitely not a favorite. Then, if you have a child who cannot tolerate the stimulants, and let's say you've tried atomoxetine and it doesn't work, there are two others that we can use. Imipramine is an old drug, and it is effective. However, I don't know that anybody uses it anymore with children for ADHD because of cardiac side effects that have been reported. And a long time ago, I think it must be about 25 years ago, there were a couple of cardiac deaths. So that if you choose to use it, please start with an EKG, and you might have to just keep monitoring over time. Bupropion, however, is a good drug. It's used for depression and very good for depression. Also has anti-ADHD effects, not as effective again as a stimulant. But if you find that there are too many side effects with stimulants, it's definitely a drug you can use. And you would start like 37.5 and go up slowly. And we'll talk about how to start medication. A relatively new one, I think must be a few years old now, is viloxazine, and it's a non-stimulant with promising results. Again, I have not used it myself with anybody, but I polled my group of child psychiatrists in the Washington, D.C. area. 2 people responded that they use it. 1 person responded that he's using it concurrently on about 30 patients. He gave very good report on it. So I'm sharing that with you, not from personal experience, but from what others are saying, and to share with you that only 2 people out of a few hundred people responded that they were using it. But it's on the market and it's approved by the FDA. How do you initiate medication? First, you talk to the families. You educate the patient and the family and get informed consent. Informed consent, letting them know what the possible side effects are. Often, the more common ones are headache, stomachache. I say you eat something in the morning before you take that pill. Definitely the mantra, start low, go slow. Explain that to parents because, when they consent to start medication, they really want to see immediate results. And it's not going to be immediate because I like to give about a couple of weeks, 10 days or so, before getting to what might be the stable dose. So start low, go slow. I also ask that parents start on the weekends when they are home so that they can actually see and monitor what's happening with their child. And it also gives them a sense of really that you're collaborating with them and empowering them to be a real participant in this decision making. Okay, here, advise the family about your expectations. No major immediate change, but you're monitoring for side effects and you anticipate the decrease in appetite and how to try to get them to eat more in the evening generally. You calibrate the medication upwards, you monitor and increase until stable. How often do you do that? Well, I would start, again, it depends on the size of the child, but I would start around 5 milligrams of, let's say, methylphenidate. Um, Start it once in the morning and let the parents see what goes on. If no problems, give another one after lunch. And then after about 3 days, start increasing. And I would increase by maybe 5 milligrams a day. And again, getting feedback all the time. Once you get to the dose that seems to be working, and of course you start with the immediate release, because let's say somebody has an anaphylactic reaction. My God, that'd be scary. They still have. You don't want to start with the long acting, okay? And once you get a stable dose of the long acting, then you can shift over to the orals or the SR or the ER, and those are usually very effective. And you want to then monitor really how early the child should start. Generally, I would say that starting before school around 6:30, 7 o'clock is a good starting time for one of those doses. It's supposed to go around 12 hours. People have different physiologies, so sometimes there might be need for a booster dose, maybe in the afternoon. But again, it's a lot of monitoring, a lot of feedback, and individualized. So what do we do with the comorbidities? So major comorbidities, impulsivity and aggression. Now, because clonidine and guanfacine can address that, those are the first ones I would go to. You will hear and read about using antipsychotics. I really hesitate to use antipsychotics for these kids. And it's I would prefer to try and even use something like Tegretol in order, carbamazepine, I should say, sorry, in order to dampen the impulsivity and aggression, because the antipsychotics cause so many side effects in terms of metabolic changes and increased weight, etc. When depression and anxiety are comorbid, if you have a mental health person working collaboratively with you, using SSRI, sertraline, fluoxetine, after ADHD stabilization. So you don't want to try and throw everything at one time. You stabilize the ADHD, then you start that. When it comes to the other bigger mental health issues, definitely you want to refer to a specialist, okay? I have had a situation where a child was in a rural area and they referred him. I was at Children's Hospital in DC at the time. I stabilized the medicine, which was polypharmacy, and then handed him back to the pediatrician in a rural area. But she and I collaborated and were able to treat with her being the primary treatment person. Okay, when you treat, it's not just medication, okay? It's so important to talk about psychoeducation. What is it? How do we help the child and the family understand what it is? And as I mentioned to you about my one family I treated, because it's inheritable, you want to say, who else in the family may have presented like this? And very often they haven't been treated. So that, not that you will treat them, but you will raise awareness that this could be existing in other family members. Now, environmental manipulation, important, because what happens if there's too much stimulation in the environment? It just activates the brain and causes more hyperactivity. So that we want to talk to parents about what goes on in the environment. Behavioral management, very often, because these kids have been often presenting, oppositional, their hyperactivity is getting in the way of them being able to settle down. We need to help parents with behavioral management. I'm not expecting primary care people to be able to do all of that, but maybe you can refer to somebody in some primary care practices. They have a behavioral person specialist who can assist with that. Also, I find that very often sleep is a problem, and I want to address that prior to medicating for ADHD, because sometimes if sleep is an isolated problem and you address the sleep problems, you see that the ADHD just disappears. And how do you address sleep problems? Well, you can use clonidine. Some people use Benadryl. So let's think about some of the medicines that you use anyway. Need for accommodations, I mentioned that before. And I think everybody is familiar with the idea and the 504s and the IEPs. But in addition, we can also help parents with their jobs get FMLA leave so that if their child needs more time and attention, that leave can promise them that they will have a job. And I've done that for several parents, for kids who are much more difficult. And I always think that when people find out that they are not alone, that there are other people dealing with the same problem, referral to helpful organizations like CHAD or other local self-help groups would be necessary. The side effects I mentioned before, headache and stomachache, having breakfast before eating and before taking the medicine is important. What I see, and especially since I'm in the school, I see that kids don't eat much at lunchtime. I try to get them to eat a banana or eat a piece of fruit, but something simple, get something in there. And talking with the parents, talk about dinner time. And what I find with most of the kids is that they tend to really fill up at dinner time. In many cases, you can see a little shift in mood. It's a little depressive, and parents are very uncomfortable with that. Let them know that we need to give the medication time for accommodation. In most cases, that goes away. If it doesn't, then you really have to start thinking, maybe this kid has a depressive disorder. The research does show that there have been concerns of growth over years, and that there is a decrease that could be, I should say. But as I mentioned to you before, I've been doing this for 40 years, and all my patients are towering over me and looking down on me. And so I haven't had any experience with that. Again, if there are concerns about cardiac problems, consult with a cardiologist a priori. I had one child where ADHD was a sole problem in terms of any other mental health issues. But he had a cardiac problem. I was able to work closely with his cardiologist. I was able to medicate him, and this kid did very well. So don't hesitate to do that kind of collaboration if you need to. Don't just simply say, oh no, I can't do this because this kid had a cardiac problem. Talk to the treating person and try. Okay, I know I have to. I quickly want to mention that since COVID, there's been a shortage of supply, and all of us providers, we struggle with getting the medication. In some cases, we've had to switch medication. And when you do that, sometimes it's not as effective, or you get new side effects, but we're doing the best we can under the circumstances. Cases from my files, I don't want to spend too much time, but because I started with these people young, in most cases, they've grown up, they've done well in school, they've gone to college. I've just had one kid. Well, he's not a kid anymore. He just graduated as a lawyer. I've had, I talked about the young lady who is a physician. I had one teacher who I saw her as an adult. She was not doing well. She couldn't pass her certification exam, diagnosed ADHD, got neuropsychological testing that certified it and treated her, and she was able to go on and progress in her career. I told you already about the children and father with ADHD. Really, I underline here that untreated ADHD does take a toll on self-esteem, because if you aren't mastering the things developmentally you're supposed to master, you don't feel good about yourself. Just quickly to mention cultural barriers. African Americans are reluctant to use drugs prescribed for behavior. There's a whole, a history of why that is so. And you don't jump in and start talking about medication. Talk about what this is. Talk about behavior management in order to try and engage people. The Hispanic population is also less inclined and wise to take medications. And this is because I live in a multicultural environment in the Washington, D.C. area. I see all of these. The Caribbean and African families tend to think of the behaviors as being willful and the children in need of harsher discipline. So there's a lot of education that has to happen there. Okay, I'm not going to go through this. We went through that before. In summary, ADHD is real, but stigma is also real. The morbidity is high and it affects across the lifespan. Excellent research, diagnoses and treatment are available. Medications in general are very effective. Case finding is not as good as it should be. We need to educate families, physicians, you are doing that, teachers, employers also as a major effort. And we also need to legislators so they don't get in the way of what. There are suggested readings, and we have 15 minutes. Thank you for listening.
Thank you, Dr. Benoit, for an excellent talk. I'm Kara Woodbury-Fladlin, Sanford Research, and on behalf of the Pediatric Mental Health Care Access Program, we just thank you very much for your talk.
It's my pleasure. I wish I could be actually with people. I much prefer that. Yes.
We'll come to you anytime. But opening it up to questions now. I will comment as well, and it was in the chat, that Nicole will be sending out the information, the slides from today's talk to people. Yes. So look for that. And maybe I can get it started with a question. I'm curious about the psychological testing. You mentioned that that is probably the preferred line is to have that testing first if you can. What kind of testing do you recommend?
Well, okay, so there are specific tests, the Vanderbilt and the Connors, that are the most prevalent that are used for ADHD. However, because so many of these kids might have learning disabilities and other issues, even intellectual disability, that if we can get all of that really documented, then we're in a better place to help that child get all the assistance he or she needs. The other thing is that what I have found, and like I said, I've been around a long time. It used to be that I could simply write, this child has ADHD, and that was acceptable. It is no longer acceptable because I think that school systems think it's being overused. I don't know, but they want more documentation. And so all school systems are not very generous about doing psych testing. But if you can refer, even they have to get in line, I would encourage that, because it will suit them better later on. Because when they have to get accommodations like more time, that might need assistive devices, that psychological testing is really important.
Yeah, totally makes sense.
And like I
Yep.
can see that's been a change because I used to be able to just say, I saw this child, I diagnosed, and that was it. That is no longer acceptable.
Yeah.
Yeah, yeah. One of my questions would be how challenging primary care health providers finding treating ADHD. As I said before, in that big study that looked at the community work versus the research work, it said that many times the kids are under medicated. And I would like to know, what are people's thoughts, feelings, experiences around something like that? If, is it uncomfortable to say, oh gosh, now I'm going up to 60 milligrams of methylphenidate?
That's an excellent question. And if anyone wants to take themselves off mute or put something in the chat about that, that would be great.
Hello. I actually have a question, but I will answer the question first. Um, no, it depends. I think a lot of it depends on where you practice. When I practiced in a city, it was a lot easier to refer patients out. So you would go up to a certain level, and then if you felt like you were not getting benefit, then you would just refer them. I now practice in rural North Dakota, so I'm it. So there isn't anywhere to send them. So the comfort level goes up, so you push. Um, the main issue that I have is time, is uh, you have an
Yeah,
advantage because you're in the school system, you can see the kid, you know what's
yeah,
going on. What I
yeah.
have is I'm depending on what the parent tells me based on what the teacher told the parent. And then watching the kid in the office, a lot of times there's a disconnect between what I see and what I hear. And so,
Absolutely.
yeah, and then trying to decide whether or not this is an indication where one, is the diagnosis right? Do I need to go up on medication? Or is it something between the kid and the school that I need to work on?
You are absolutely right. And that's complicated because I'll tell you, in my experience, and so, I've been in the school and I've been in places where I haven't been in the school to observe. What I have found is that when the parent child come to you for the meeting, that when you ask for feedback, the feedback you get is the most recent behavior. So let's say you're seeing them on a monthly basis. I used to see kids at foster care on a monthly basis. And it was a social worker. And I said, no, I want to see the foster parent. And all I would get initially was what happened that week. What was the bad behavior that week? And that then can cause you, the prescriber, to medicate to the most recent behavior. And that's not good, okay? Because what happened in the environment to stimulate that behavior, okay? So that's why it's important, I think, if you can talk to the parent, guardian, somebody, to keep something on perhaps a weekly basis. If you can ask the teacher to give you a weekly report. But that takes a lot of collaboration. And I understand the whole issue of time. But you are right. And what you see in your room doesn't match so it's very complicated, and that's why we need that collaborative involvement. And I think at the very beginning, when you're starting the medication, you talk to the parent about that, talk to the parent about, how to engage the teacher, because those three things are so critical in terms of really understanding what's happening with the child. I'll give you a quick thing. And remember, I mentioned PTSD, okay? And I don't want you to forget that that is something to look at. And in this foster care clinic where I was working, so the kid comes in and they said that, well, he just hit the aide on the bus and therefore he needs medication, okay? And so I wanted to know what was going on. Long story short, it turns out that he's in a closed bus and something altercation happened. And he said to me that the way the aide looked at him was the same way his mother, his abusive mother, would look at him before she would physically abuse him. And he just, the brain just reacted. Bam, he was hitting her. So we need to know more than just what happened, but why did it happen? How did it happen? And I know you all don't have a lot of time, but if you can, at the beginning, prime the parent guardian to be prepared when they come to see you with that kind of information and also what comes from the teacher.
Thank you.
No, you're welcome. And the other thing I would say is if you can link up with a child and adolescent psychiatry in your region, each one of the regions have what we call a regional council of child and adolescent psychiatrists. And I think that to reach out and engage in some parts of the country that is happening so that you can have somebody to call and say, listen, the old way we used to practice, you used to call and talk to your friend and see if you can engage with somebody like that.
Yeah.
Because I think there's a whole lot you can do with just a little bit of help, perhaps from somebody more experienced. And feel more comfortable, because I think that your comfort level is important.
Thank you.
Okay.
I do have a question, if you still have time.
Of course.
I appreciated your story about noticing the mother who was depressed and being able to then focus on the mom in order to help the kid. I've had the opposite effect when looking at the family or the family dynamics and realizing that the kid's behavior is a reflection of what's happening in the family, but could not get the family to agree to seek help. It was only the kid's problem. It wasn't the family's problem. And so I tried to get that way going through like family counseling.
Yes.
But they absolutely refused.
Yeah.
And at that time, the counselor that I was working with refused to see the kid without the family. So it was like, neither one of them would give. I needed a way to get in, and neither one would allow me to do that. So do you have any suggestions or recommendations about how play that game?
Okay. And that unfortunately happens a lot. Unfortunately. You have done all that you could do, okay? And in terms of letting the family know what your observations are, the referral, you can't do any more. And I have to share with you that sometimes we come up against a wall like that. And at this school that I'm working at, we just kind of turn to each other and say, we're doing the best we can. I am fortunate enough that we have a social worker. We actually go into the homes and have been able to do that, and that helps. But it's not, most people can't do that. So you just did the best you could. I can think of a situation where, again, the kid was brought for ADHD. both parents professionals in the medical field, a nurse and a doctor. Yes, I thought that there were things going on in the family and I couldn't get in. Okay. Guess what happened later on? Father got arrested and was found with drugs, and his specialty had him exposed to a lot of drugs that you had access to. And long story short, he was able to go into rehab. And the kid actually didn't have ADHD. Yeah. So, there are family issues going on, and many families are very closed and unable to let you in. You do the best you can and try. And, I feel bad when that happens. I'm glad you brought that up because I imagine many people must experience similar issues.
Thank you, Dr. Benoit, again for your insights and excellent talk. I see we're at time. Nicole, do you have any other final details to cover?
Nope, just be looking at your email. I'll send the slides out. I will also send the link to the evaluation in case you didn't get a chance to complete that. Thank you so much for joining us today.
Well, thank you. Thank you. I appreciate it. And thanks for all the help with the technology and all that.
Thank you.
Have a good afternoon.
Thank you.
Yep.
Bye.
Bye.